much. And my name is Norimichi Higurashi, and I'm from Tokyo. And I deeply appreciate for giving me an opportunity to give a talk on such a very exciting and updated conference on PCDH19. It's my great pleasure and honor. So as you can see, I'm a very young doctor, but I hope that my talk today could be of some help to the patients as well as future research on PCDH19. Today, I will talk about the clinical characteristics and the treatments of Japanese patients with PCDH19-related epilepsy, especially focusing on the early seizure characteristics, including the differential points from Dravet syndrome and the excellent efficacy of glucocorticoids, which may become a powerful therapeutic option of this disease, I suppose. So, because PCDH19-related epilepsy is a genetic epilepsy, early and correct diagnosis can be made by genetic analysis. And thus, it will lead to the correct treatment based on the molecular pathomechanisms in the future. But even in the current situation, early diagnosis is crucial to improve the neurological outcome of this disease. Although it is currently well known that Dravet phenotype is minor in the PCDH19-related epilepsy, diagnostic confusion may commonly occur in clinical situation during early stages. However, SCNY-related Dravet syndrome should be discriminated early because the therapeutic strategies were completely different. In Dravet syndrome, early intervention with effective treatment for its prolonged convulsive seizure is important. Conversely, in PCDH19-related epilepsy, it may be, I suppose, be very essential to minimize the use of antiepileptic drugs to avoid their harmful influences, especially on the intellectual development. So we have so far identified 30 Japanese patients in 25 families. In 22 families, sequence abnormalities were identified. As reported in the other studies, location of the mutations were highly concentrated in exon 1. In the downstream exons, only 2 mutations were identified in exon 2 and exon 4, and both were nonsense mutations. As you know, exon 1 encodes the extracellular cadherin repeats that are important for the cell-cell interaction. Considering such genetic characteristics of the patient's mutation, disruption of such interaction via proto-cadherin-19 molecule will be an essential part of this disease pathogenesis. 3 other patients had a whole PCDH19 deletion that was identified by using MLPA and FISH analysis. So the frequency of gene deletion is 12.5% among the total Japanese province. The clinical features of our patients were also basically identical with those of the patients reported from the other countries. Early seizure onset, brief habitual seizures, repetitive seizure clusters, and a high rate of fever sensitivity. Our patients mostly exhibited focal seizures. Generalized tonic and tonic-clonic seizures were also often reported. Seizure clusters were strong and frequently repeated during the early stages and gradually decreased thereafter, followed by remission in teenage years. Intellectual disabilities and autistic hyperactive features were also frequent. Motor outcome was excellent, and all patients could walk independently at the last follow-up without ataxia and spasticity. Phenotypic variations of this disease have been well described. Some of our patients had a mild phenotype with only occasional seizures during early childhood and normal intelligence. This shows an example of such phenotypic variations. A monozygotic twin case, elder sister had frequent febrile or afebrile seizures clusters that are intractable to multiple treatments and border intelligence. But the younger sister experienced isolated generalized convulsions only twice with a fever at the age of 2 that disappeared under valproate monotherapy and had a high intelligence level. They must have almost identical genetic background, so which indicates that the clinical pictures can be significantly influenced by some modifying factors other than PCDH19. The onset ages ranges between 4 and 25 months of age. 3 patients with later onset here were all mild cases with as much clinical attention. The core patient had onset until 30 months, averagely around 7 or 8 months. The earliest onset reported was 3 months, so onset before 3 months is not likely in this disease, I think. So seizure clusters and fever sensitivity were identified in all patients excluding mild cases. They persisted throughout the clinical course. Each cluster averagely continued for a few days to 2 weeks or so, but sometimes longer, especially during the early phase of the disease. Although seizures frequently repeated during clusters, our patients generally had a clear consciousness between seizures, except for the possible influences of high fever and anticonvulsive therapy. Some patients occasionally showed strenuous clusters that needed to be suppressed immediately, especially during early childhood. Febrile seizure recurrences were also common. But in such cases, patients mostly suffered some viral infection or other sick conditions. 4 patients had experienced seizures during hot water immersion as observed in Dravet syndrome, indicating a possibility of sensitivity to increasing temperature. But I personally suppose that some inflammatory processes may be significantly involved in this disease. I will talk this later. So to identify early clinical clues indicating the possibility of this disease, we investigated the details of the initial episode in 6 patients, and 2 patterns of seizure clusters were found. One is shown here, biphasic short seizure clusters that was observed in 2 patients. In this, the first phase appeared during fever and consisting of many seizures. This continued for a few days and remitted with decline of fever. But after several days of seizure-free period, a febrile clusters recurred and continued for several days again. In these 2 patients, motor development was delayed before onset. I don't know the reason why. So the other 4 patients with normal initial development exhibited prolonged course of seizure clusters. 2 patients are shown here. Both patients had onset at the age of 10 months. Seizures started during fever, but repeated only a few times and disappeared soon with decline of fever. But after days of seizure-free period, a febrile clusters consisting of frequent seizures recurred and intermittently persisted for over weeks. In the case shown above, here, so some kind of encephalitis was suspected when the febrile seizure clusters recurred, and its treatment, including methylprednisolone, was performed here. Very interestingly, this treatment suppressed only transiently, but completely the seizures for a week. So in cases with such a prolonged course of seizure cluster or the bi- or multiphasic clusters without any obvious causes, it would be better to consider PCDH19 analysis even at the initial episode. So duration of each seizure was generally brief, up to minutes, and momentary seizures up to a few seconds were also often observed. Only 4 patients uncommonly experienced prolonged seizures over 15 minutes, but none of the patients experienced the persistent clonic seizure as observed in Dravet syndrome. As reported, focal seizure was the primary seizure type also in our patients. Frequently reported symptoms included loss of consciousness, eye deviation, respiratory alteration, facial cyanosis, tonic posturing, facial and/or limb small twitching, massive systemic jerks, complex fine movement in a hand or foot, and sometimes subsequent generalization. In ictal EEG recordings, seizure activities frequently started in the front temporal region. Affective ictal features were observed in some of our patients, but we could not thoroughly investigate whether fearful screaming were frequent in our patients. In any case, it is clinically and electrophysiologically obvious that PCDH19 seizures strongly involve the front temporal regions, especially, I guess, medial frontal and the limbic system, since it's very early stages. Regarding generalized seizures, tonic and tonic-clonic seizures were common, but they may highly include focal tonic seizures and focal seizures with rapid generalization. Chronic component was often unclear in our patients. In ictal EEG recordings, primary generalized seizures could not be recorded in our patients. So I guess primary generalized seizures might be much less common compared to the focal onset seizures. More importantly, none of our patients presented with myoclonic and absent seizures. So, well, let me show you some examples of the ictal EEG. This is a trace of a patient with a nonsense mutation recorded at the age of 2 years. This seizure consisted of a mild tonic component in the limbs and a blank stare. Ictal activities started in the right front polar region, and followed by rapidly spread to the right frontal and right front temporal region, and more posterior related regions. So the ictal activities disappeared in the original starting region in 8 seconds, but the ictal activities remained for a few seconds in the contralateral frontal region. So let me show you another example. This is a seizure video. Again. So this seizure started with a mild fraction of the left arm. Mild fraction of the left arm followed by a momentary massive systemic extension and finished with fine movement in the left hand and the foot. So at a glance, this seizure appeared a myoclonic seizure, but this is obviously focal seizure. The seizure started in the vertical line here, and the systemic jerky extension had already finished before the somewhat diffuse but irregular spike or spike wave observed in the left hemisphere. In the right side, different unsynchronized activities were observed. If PCDH19 patient exhibited myoclonic-like seizures, ictal EEG recording is essential because this type of momentary movement was commonly observed in conjunction with the focal seizures in our patients. So if patients apparently exhibited myoclonic or absent seizures, especially during later childhood, some other genetic or developmental factors of the brain network may be involved. Interictal EEG commonly showed focal spikes and the slowing of background activities or the basic rhythm. In most cases, these findings were unstable and easily changed test by test. Although spike waves sometimes appeared in a diffuse fashion during school age and puberty, patients never exhibited during early childhood. which is an important feature in Dravet syndrome. So this is a summary of seizure types in PCDH19 in comparison with those in Dravet syndrome. Again, focal seizures are primary in PCDH19 and mostly appear since the onset. Ictal features often included frontal symptoms. In Dravet syndrome, focal seizures were also frequent, mainly appear after infancy, and often exhibit temporal types of complex partial seizures or simple motor seizures. The other point is, in Dravet syndrome, early hypersensitivity of thalamocortical network is crucial, which is represented by early appearance of myoclonic absence and generalized spike and wave discharge, as well as prolonged clonic seizures. PCDH19-related epilepsy lacks such features. These differences may help speculate whether the patient has Dravet or not. In any case, the most clear and important thing is to consider early genetic analysis. So, regarding the therapy, efficacy of oral antiepileptics of our patients is shown here. This data was collected from attending doctors via questionnaire, and the efficacy was classified according to the definition presented in the right. In this data, phenytoin, potassium bromide, clobazam, and topiramate were often effective. But despite its primary nature of focal epilepsy, carbamazepine and phenobarbital were ineffective in most cases. Probably carbamazepine is started during the very early stages of this disease in our patients. So that is a possible factor. So of course, I could not say anything definite by this data, and a more rigorous investigation should be done. Furthermore, the current data does not include many new generation drugs, such as lamotrigine and levetiracetam. However, importantly, there was no drug that constantly could prevent or decrease further clusters. So in the next step, it will be essential to focus on some modifying pathogenic processes that accelerate the intractability of this disease. Regarding the acute treatment, midazolam was most frequently used in a patient. If the clusters were mild, low dose of continuous midazolam effectively suppressed clusters, but cessation of midazolam often caused seizure recurrence, and long-term treatment was often necessary. In cases of severe clusters, especially in younger patients, midazolam was often ineffective, and phenytoin or phenobarbital was administered, but which showed only transient efficacy. So thiopental was occasionally administered when seizure was severe, but its efficacy was often insufficient because seizures were generally brief and the intellectual consciousness was clear. Observation without intravenous anticonvulsant may be recommended. But what I want to emphasize today is the excellent and immediate efficacy of glucocorticoids. Methylprednisolone was used in 3 of our patients. The first case is a patient that I presented in the previous slide as a patient with prolonged seizure cluster. In that case, steroid was used as a part of treatment for suspected encephalitis and suppressed clusters completely for a week. Other 2 patients initially exhibited recurrent clusters consisting of frequent seizures, and each cluster continues for days to 2 weeks. In the number 2 patient, the indicated dosages of methylprednisolone were administered in 4 opportunities of recurrences at the age of 2 and 3 years. In all opportunities, seizures disappeared immediately after the first administration. So I'll show you the details of the number 3 patient. Number 3 patient developed febrile clusters at the age of 5, 7, and 10 months, followed by febrile clusters at the age of 11, 14, and 19 months. Although no seizures occurred between the clusters, 30 to up to 100 focal seizures appeared a day during cluster, and that continued for 3 days to 2 weeks. Midazolam showed a limited efficacy, and several oral antiepileptics failed to prevent seizures. The 7th cluster appeared at the age of 1 year and 11 months without fever, and frequent seizures appeared. Midazolam was insufficient, so 20 milligram per kilogram of methylprednisolone was administered on the 2nd and the 3rd day of the cluster. Seizures disappeared right after the initial administration and do not recur for at least 3 months until now. Although now not presented in the slide, another patient also showed excellent efficacy of steroid. She was received 1 milligram per kilogram per day of oral prednisolone when clusters recurred at the age of 10 years of age. Even with oral administration and even during puberty, even in lower dosages, quick and excellent responses could be obtained. So I'm privately supporting that some inflammatory processes may be involved as a modifier of this disease. Seizure recurrence clearly depends on the occurrence of infectious diseases with or without fever. Duration of clusters appeared not influenced by anticonvulsant treatment. Phasic recurrences of clusters with long seizure-free intervals between the clusters without regular occurrence of seizures, interactability to many antiepileptic drugs, and excellent efficacy of glucocorticoids. This may support my speculation. Many studies have revealed that inflammation and blood-brain barrier damage significantly promote the seizure occurrence and the development of epileptogenesis. It is also known that systemic or peripheral inflammation could spread into the central nervous system directly or by damaged BBB. And the extravasation of blood-borne molecules could induce seizures. Furthermore, seizure clusters themselves provoked inflammatory processes in the CNS and accelerate BBB damage. So if PCDH19 abnormality is prone to cause CNS inflammation in the response to systemic inflammation or to induce BBB vulnerability, seizures might easily occur when patients get some viral infection even without obvious encephalitis. Glucocorticoids significantly stabilize BBB, and so in this disease, they could immediately relieve seizures by a restoration of BBB integrity. However, currently, I don't have any evidence that supports this speculation. Sorry, this is the last slide. As reported in the patients of the other countries, Japanese patients showed early onset seizure clusters consisting of brief seizures, focal seizures often involving front temporal region, and fever or infection sensitivity. The patterns of initial phasic or prolonged clusters could be a clue to suspect of this disease. Lack of early hypersensitivity of thermocortical networks is the important difference from Dravet syndrome. Glucocorticoid will show a significant efficacy for suppressing ongoing seizures. Regarding its mechanism, dosage, and treatment strategies, further investigations are necessary. Minimum regular use of oral antiepileptics combined with the short-term addition of steroid when cluster recurred might be a possible treatment style of this disease. It will also be important to avoid excessive administration of antiepileptics. Thank you very much.